Chlamydia trachomatis sexually transmitted infections. Funmi Adewale. MLS 205, Microbiology. Objectives. After the presentation, the audience will be able to summarize the natural history of the sexually transmitted infection chlamydia, outline the life cycle of the bacterial species Chlamydia trachomatis, determine which serotypes of Chlamydia trachomatis are most associated with STIs, propose an explanations for the recent trends in chlamydia prevalence, discriminate between the various diagnostic methods for Chlamydia trachomatis according to their targets, specificities and sensitivities, assess which specimens are acceptable and which diagnostic methods are recommended given the patient's circumstances, describe treatment options for patients diagnosed with Chlamydia trachomatis STIs, predict future trends and prevalence based on public health prevention efforts. Chlamydia. Second most common sexually transmitted infection, STI, in US after HPV, most common bacterial STI. Caused by infection with Chlamydia trachomatis. Obligate intracellular parasite, cannot make ATP. Infects non-ciliated columnar cells, conjunctiva, urogenital tract, rectum, pharynx. Transmitted through sexual intercourse. Most initial infections are asymptomatic, last for months to years. Repeat infections are common. Easily treated. Retrieved from Mayan, C. Lehman, D. and Monocelis, G. 2015. Textbook of Diagnostic Microbiology. Maryland Heights, Missouri, Elsevier/Saunders. Risk factors: age, less than 25. Race, infection 5 times greater in blacks compared to whites. Sexual activity. Hash of partners. New partners. Men have sex with men, MSM. Retrieved from Turney, E., Papp, J., and Weinstock, H., 2014. Prevalence of Chlamydia trachomatis genital infection among persons aged 14 to 39 years, United States, 2007 to 2012. MMWR, Morbidity and Mortality Weekly Report, 6338, 834 to 838. Not much known. 6% positivity rate as of CDC's monitoring in 2005. Clinical presentation. Retrieved from http://www.drugs.com/mcd/cervicitis. Clinical presentation. Majority of infections are asymptomatic. Primary symptoms. Cervicitis in women. Non-gonococcal urethritis in men. Progresses to epididymitis. Sequelae include pelvic inflammatory disease, infection/inflammation of uterus, fallopian tubes, ovaries, peritoneal cavity. Ectopic pregnancy. Tubal infertility. Lymphogranuloma venereum, a more severe disease caused by AL13 cerevars, rarely seen in the US. In neonates, can lead to pneumonia. Conjunctivitis. Retrieved from http://www.riversideonline.com/health_reference/menshealth ds00603.cfm. Mucopurulent discharge. Upper tract infection, most common cause of epididymitis. LGV is invasive, lymphatics, and rarely seen in US. Life cycle of C. trachomatis. Retrieved from Mayan, C. Lehman, D. and Monocelis, G. 2015. Textbook of Diagnostic Microbiology. Maryland Heights, Missouri, Elsevier/Saunders. Elementary body, EB, infectious, metabolically inactive, extracellular and enveloped, gram-negative elements equals LPS. Reticulate body, Arabe, non-infectious, metabolically active, intracellular. Diagnostic text, structural and genetic features. Serotyping based on major outer membrane protein, MOMP, species specific. Cerebrars DK responsible for non-LGV STIs. Lipopolysaccharide, LPS, genus specific. Genetics. Cryptic plasmid, greater than 99% of C. trachomatis. Retrieved from Land, J. A. Van Bergen, J. E. Moore, S. A. and Postma, M. J. 2010. Epidemiology of chlamydia trachomatis infection in women and the cost-effectiveness of screening. Human Reproduction Update, 16-2, 189-204. Unknown purpose. Diagnosis, methods culture non-culture. Recommended method for diagnosis and legal investigation of Code 600 in children. Culture. Shell vial method. 96 well microtiter plate method. Non-culture. Surface antigens, MOM4 LPS. Direct fluorescent antibody, DFA, tests. Enzyme immunoassays. Nucleic acid. Nucleic acid probe tests. Nucleic acid amplification testing. Recommended method for screening/diagnosis, Code 600 in adults. Shell vial is more accurate in 96 well BC. It requires more inoculum and has less risk of cross-contamination. Blind pass. First incubation monolayer is disturbed and used to re-inoculate second monolayer to improve sensitivity. Analysis. Light microscopy visualization for cytopathic effect, stain with fluorescein conjugated IMAB for visualization. Issues with culture, turnaround time, poor standardization, labor intensive, requires technical skill, highly dependent on specimen quality. DFA, specimen rolled onto slide, flooded with a stain of fluorescein labeled IMAB that react with either MOM4 LPS, cross-reactivity, antigens. Antibodies react with LPS, cross-reactivity, then detected through enzyme assay, for example HRP. Diagnosis, methods. Retrieved from Mahan, C. Lehman, D. and Monocelis, G. 2015. Textbook of Diagnostic Microbiology. Maryland Heights, Missouri, Elsevier/Saunders. Culture is poor sensitivity, missing a lot of infections, but excellent specificity, gold standard. Diagnosis, specimens. Specimen of choice, according to CDC recommendations. Men, urine, as good as or superior to urethral swabs. Women, vaginal swab, as good as endocervical swabs. In women, urine is acceptable for screening, but may reduce sensitivity, up to 10% of infections missed. Extragenital sites, rectal and oropharyngeal, not much research, but amplification tests recommended. Collection, transport and storage. Transport media for swabs varies depending on diagnostic method. Regardless of method, should be refrigerated, 4 degrees Celsius, immediately. Long-term storage ranges from -10 degrees Celsius to -30 degrees Celsius for varying durations. And less invasive. Prognosis and treatment. Excellent prognosis, given of treatment compliance. Single-dose oral azithromycin or 1-week course of doxycycline. Expedited partner therapy, prescribing medication for sexual partner of diagnosed patient without examining partner. Proven to reduce repeat infections in females. Sanctioned by the CDC. As of 2010, only legal in 27 states. Prevention, screening. CDC recommends annual screening for all sexually active women under the age of 25. Sexually active women 25 and over if determined to be at increased risk, for example new or multiple sexual partners. Men who have sex with men, MSM. CDC also recommends screening for repeat infection 3 to 12 months after initial diagnosis. No screening recommended for heterosexual men unless high prevalence settings, for example correctional facilities. Partners of infected women. Barriers to screening, insurance, young adults, privacy, adolescents, awareness, provider failure to offer screening. BIOP, bring your own partner, when patients are called and informed of positive results, advice to bring partner with them during follow-up. Chlamydia trachomatis STIs, summary. Most prevalent bacterial STI in United States. Obligate intracellular parasite of columnar epithelium. Cerevirus DK cause most of the infections seen in U.S. Nucleic acid amplification testing is recommended diagnostic method, except in children. Theoretically easy to reduce prevalence. Easy to prevent transmission, safe sex practices, for example free condoms by mail and CA. Easy to minimize spread, sensitive diagnostic methods equals greater than less invasive specimen collection equals greater than increased screening / more accurate diagnostic testing. Easily treated. Areas that need improvement. Increasing initial screening rates, especially in at-risk populations, under age of 25, Blacks, MSM. Free, at-home test kits by mail in Los Angeles. Increasing reinfection testing by providers 3 to 12 months after initial infection. CA Health Department, Family Health Council. LA Health Department.